Good morning, honorable members of PSK, other healthcare professionals who have joined this call, our distinguished panelists and my colleagues from PSK office. Welcome to this edition of Pharmacy COVID-19 Dialogues. Today, we are focusing on a multidisciplinary approach to COVID-19 response. And we are featuring a team from Mama Lucy Kibaki Hospital, a team of 5 people from various disciplines to just enlighten us on what they're doing in response to COVID-19. My name is Dr. Daniela Munene, and I'm the CEO of the Pharmaceutical Society of Kenya. I'll be your host for this webinar. And I want to extend a very warm welcome to you all. So I'd like to introduce our moderator who will take us through the program today. Dr. Michael Mungoma was not able to make it, even though he intended to join us. He's held up. But we have moderating for us today, Dr. Sylvia Opanga. She's a member of PSK and she's a senior lecturer at the School of Pharmacy, University of Nairobi. She's also the chair of the Education and Public Health Committee of PSK COVID-19 Response Task Force. Karibu sana, Dr. Opanga.
Thank you. Yes, so good morning, everyone. Welcome to today's webinar. And before we start, just a few ground rules and announcements. Participants are muted during the entire course of the webinar. Please ask questions via the Q&A tab at the bottom of your window. Don't field your questions in the chat tab. Questions shall be addressed later by panelists in the program. For PSK members, if you are not already done so, please subscribe on PPD portal for today's webinar so that you can get your CPD points. Please note that CPD points will only be awarded to paid up members, and this webinar is being recorded and the audio will be made available on PSK's YouTube page. Let me go ahead and introduce our speakers. Our first speaker is Dr. Josephine Wambui Nguri. She's a clinical pharmacist with over 10 years of professional experience in the public health sector. She has specialized in pediatric pharmacotherapy from the University of Nairobi and has been in senior management at Mama Lucy Kibaki Hospital for over 2 years. She's a member of the hospital COVID-19 RRT Rapid Response Team, PSK PR Committee member, and a co-founding strategist for PSK Mentorship Initiative. Dr. Nguri is passionate about infection prevention and control, antimicrobial stewardship, and clinical research. Welcome, Dr. Nguri.
Thank you, Sylvia.
Our next speaker is Dr. Dorothy Waweru. Dorothy Waweru. She's a Chief Public Health Officer at the Mama Lucy Kibaki Hospital. She has over 20 years of experience in Kenya's health sector. She has also over 10 years of experience in administration and management and is a member of the Rapid Response Team at Mama Lucy Kibaki Hospital. Welcome, Dorothy. We have the next speaker, who is Dr. Emadau Karen. He's a medical doctor and a child health and pediatric specialist. Currently, she's heading the pediatric department at Mama Lucy Kibaki Hospital and serves as a member of the pediatrics COVID-19 response team. She has training and experience in dangerous pathogens and management of children's health services in disaster. Welcome, Dr. Emadau. I will also like to introduce 2 additional panelists from Mama Lucy Kibaki Hospital. Our 2 panelists will join us in the Q&A session after the 3 speakers have given their presentations. Our panelists include Dr. Florence Namisi, who is a medical doctor and an infectious disease specialist, and she is the chairperson of the Rapid Response Team at Mama Lucy Kibaki Hospital. Our last panelist is Fatia Swaleh. Fatia is a medical laboratory technologist with a BSc in medical laboratory sciences. She has over 20 years professional experience and has been a lab manager for over 10 years. Welcome, Fatia. And so I would like to go straight to the agenda. So we start at 11:05 a.m. with Dr. Josephine Nguri. Will be followed by Dorothy Waweru, and then Dr. Emadau Karen will have the third presentation. At midday, we'll have a Q&A session, which the panelists, the other two panelists, will also be involved in. So I'd like to hand over to Dr. Josephine Nguri to start their presentation. Thank you and welcome.
Thank you, Sylvia. So good morning, everyone. My name is Dr. Josephine. I'm here with our team and I'm so honored to be the one to represent our experiences as the entire rapid response team. So I'll not take entire credit for this presentation. We did it as a team, and most of the people in our team are actually, I feel, more experienced in infection prevention and especially viral infection prevention than I am. So I think I feel quite honored to be the one representing. So let me go quickly. This is an overview. Quickly for a disclaimer, we are not yet a treatment center. So this is our experience in terms of what we are doing since the time the country announced its first case of COVID-19. So this is an outline of what we're going to go through. Next slide, please. So Mama Lucy Kibaki Hospital is a level 4 hospital. It's located in Kayole, Eastlands, and it serves the larger Eastlands area. People come from Ruai, the whole of Eastlands. We have people who come from Kangundo as well. And it has currently, it's a 130 bed capacity, even though we are trying to expand. We have a 70 bed capacity building awaiting opening. And then the general outpatient attendance as at 2019 had about 200,000. This is both new clients and revisits, and about 21,000 admissions and discharges. Next slide, please. So that is our beautiful, beautiful hospital made for us by the Chinese government. Must be the only hospital currently with a cabral parking area. As you can see there, it's actually a very busy hospital, especially the outpatient department is extremely, extremely busy. Next slide, please. So our rapid response team was formed as a directive from the ministry after the first case was identified in March. And we immediately embarked on having a team, a multidisciplinary team that was going to have as many disciplines as possible. So we had people who had experience with epidemiology. We had infection control specialists, or the ones who run IPC in the hospital. We had pharmacy represented as well. Then people in the management, the whole of administration as well represented as well. Procurement, lab, public health, then what else? Nursing department as well. And then we also had various partners coming in to help us as well to set up the team. MSF played a big role. Then we had as well Afya Jijini bringing in a few volunteers to help us set up, because at that time it was quite unclear what we were meant to do. So we were just trying to do what we could do, especially with IPC, and to protect staff, as well as try and identify suspected cases of COVID-19. Next slide. So on containment and case identification, this is what we did from March. So we set up a triage system. Our outpatient department at that time was quite congested, especially Mondays were very crazy days. You'd have social distancing was just a thing we had never heard of at that time. So we had to put up tents outside so that we'd have the triage area being done outside and patients waiting outside as well in tents. So we moved all our triaging outside. And then we moved the tents. We put up tents outside. We had 3 tents outside where we were separating pediatrics and adults, as well as we had a tool. We were administering a questionnaire where I would at that time use the case identification. Sorry, it was the case definition that was being given by the ministers then, to put aside patients who are suspected before they're fully screened. So based on temperature, fever, the ones who came with fever, the ones who had history of travel, the ones who had symptoms, we put them on one tent, which at that time we were calling it tent A. So, and then at that time there were many challenges, because also would have, like, for example, pediatrics. I'm sure Dr. Amada will comment on this later. Pediatrics, all children come to hospital presenting with fever. Many of them, a big majority. So at that time it was a bit strange. We didn't know, do we also put patients in that tent with fever? Do we only put adults? So these are among the challenges we experienced at that time. And then the case definition kept on changing as well. As you're aware, right now we are on community transmission. By then it was anyone with history of travel from the countries that were reporting COVID-19 cases by that time in March. Then we're also doing a lot of surveillance through our public health team, that is with contact tracing. The ones who came and were suspected, again, by then we were also not doing sample collection. We're only holding patients. And the ones who had history were falling in the case definition will be put in a holding area, which is a separate tent. And then an ambulance would come and pick them for sample collection. Next slide, please. So on sample collection, I'm sure Fatia will talk more about this later once I'm done. Currently, we're doing it within the hospital. By March when we started, we're not doing any sample collection, but we have since started doing sample collection. So right now, any patient who comes and is suspected to be a COVID-19 positive case or is a suspect, we'll call in the lab team. They'll come, they'll wear full PPE, then go collect samples, whether it's in the outpatient area, A&D, in the ward. Sometimes we have had issues in theater as well. So they'll go collect samples from there. Then now send them over for, dispatch them maybe to, is it Cambridge and the National Health Referral Lab. That's where now they would do that. And then the results will be relayed back to us using the hospital email. And then we'll be able to disseminate to the concerned departments. But usually the other challenge with that is that the patient would have to be held somewhere, isolated somewhere, up until the results come back. You'll see later that some of our challenges are amongst how long sometimes it takes to get these results back, sometimes. Then the sub-county team also helps us with supplying the media and the swabs needed for carrying the samples. Next slide, please. On staff protection strategies, we've been doing a lot of training and sensitization, especially our public health team does a lot of this. So we train technical and clinical staff, support staff as well, especially on IPC protection measures. And there's a lot of anxiety with COVID, as you have seen right now. Are we safe? Am I sick? What do I do to protect myself? What do I do to protect my family? So by that time, there was a lot of anxiety. We had cases, we could hear cases in other hospitals where health workers would run away when they hear someone mentioning they're suspecting to be having COVID at that time, or they were close to someone who had COVID. So the strategy we're doing at that time is to do away with that kind of stigma and fear as well. So we trained several technical staff and then support staff as well, because most of the cleaning is done by our support staff. Next slide. This is a picture of what we've been doing at our hospital entry area. This is the picture here is the gate. What is actually took this photo yesterday. So we have hand washing that we do at the gate. Once patients enter, the ones who come walking, they wash their hands. There's a large washing area there. So they wash their hands, they have their temperatures checked. And then they go through the first tent A, where the tool is administered. Questions are asked. Do you have history of travel? Have you been in contact with a patient who has been identified to to be positive with COVID-19. And then there are also patients who bring themselves and they're saying they want to be tested. So that's where they don't go into the outpatient area to mix with the other patients. So they stay in that tent until the lab technician is able to communicate on how they're going to collect samples from them. Then also we do take temperatures as is happening in the rest of the country from people as well driving in cars. And we use hand sanitizers for the ones who are driving in cars, since for them to get out and wash their hands can be a bit challenging. Dorothy will talk more about this, the solutions we use for hand washing, because sometimes we use chlorine solution, sometimes we use soap and water, depending on what is available and what can be done fast. Next slide. Again, on hand washing strategies, staff protection strategies, I've talked about hand washing and infection control. Crowd control is crucial during this time. We went ahead and stopped patient visitation and restricted to only one visitor per day. By then we had two or three visitations schedules during the day. This has been still a challenge because trying to convince relatives they can't come as many as possible to visit their loved one is not easy. And then waiting areas, like I said, we moved them outdoors to tents. Then special clinics were put on hold at that time, but we've recently reopened them with fewer patients per clinic visit. Then we have the ones who are stable being given longer appointment periods, maybe about 4 months. And then there are those ones who come directly and do their pharmacy refills, the ones who are stable. I think moving forward, also there's a strategy where they'll just come have their vitals taken. And then if they're stable, the prescription can be refilled, since initially it's given for about, let's say, 4 months. Then this is what again, we're talking about on information sharing to patients, letting them know the reason we're doing this, because there are those who are used to coming every day, having their clinics, not every day, every month. The fact that they're being moved to further 4 months has to be very well explained to the patient, and also to reassure them that should they need to urgently see a doctor, what to do, how to monitor probably vitals at their nearest facility, or if possible, if they're able to do it at home. Next slide. We also the use of floor stickers, which we have been using when patients need to queue, for example, for registration, for payments. It has helped us again achieve the social distancing measures. Then handling of COVID-19 bodies is done using a special protocol. This will be covered by Dorothy in the next presentation. Next slide, please. On challenges, I talked about the delays in lab results. These results can sometimes take up to 4 days, sometimes, and it causes a lot of anxiety amongst staff, the patients and relatives. Then there's usually sometimes communication breakdown, like I'm saying, if the results are late, we are not sure who to contact, how do you go about it? Or maybe we had one thing in the media, then maybe locally that's not what we are doing. There's a bit of, like you have experienced, maybe because it's a new disease, various communication channels will sometimes say different things. Then protocols can be inconsistent. Sometimes local protocols say one thing, national protocols say the other thing. WHO is also saying something else. Then physical infrastructure at Mama Lucy is a huge challenge. As much as you've seen, the building is beautiful and everything, we love it, but we're really challenged with space. And as you can see, there's a requirement to isolate all suspected cases. This is a huge challenge, especially in our accident and emergency area. And even in our lab, like maternity and theater has been a big challenge. So that's still a huge challenge. And then the curfew and lockdown measures, when they happen, the one that was like 7 p.m., everybody had to be home. We had members of staff who use public means. By then, matatus were not even allowed to operate past that curfew time. So we had to readjust our rotas to suit accordingly in order to be able to accommodate those people who need to go home using public means. That really affected us. Then PPE shortage, which has been global, has been a big challenge, especially with N95s. And And this can also pose a challenge with collecting samples at night. We don't have enough trained lab personnel who are trained to collect samples. And then the coveralls, which are not as many, sometimes are not enough. So I think nighttime is the difficulty. I think the lab personnel will be able to tell us this more. Fatia is here with us. Next slide, please. This is my favorite, learning points. What we have learned a lot. Anything that comes and is new, at first will be really frightening and weird, but we have learned especially on how to utilize what is available. And availability of PPE and commodities made us become more innovative and accountable for whatever we had at that time. Currently, we are having staff members sign in for each mask they receive. There's a book they sign and they say how many they have received. And then each department has to sign, say how many they have picked, and give back, come back with feedback on how they have utilized whatever they received. May it be gloves, may it be masks, coveralls, even sanitizers, because at that time, sanitizers were a big deal. You put your sanitizer in the pocket, and if you remove it and put it on top of your table, the next time you turn around, it's not there. So we have had to be accountable with all that. Then we had to train people on how to rationally use masks. And then we received even several donations on cloth masks from various partners. So we were advocating for our non-clinical staff, the ones who are not necessarily dealing directly with patients. Maybe you probably sit in the office most of the time, you do procurement or accounts work, you're not necessarily dealing directly with patients. We have been advocating for them to use the 3-ply cloth masks, which has been very useful. And this has helped us to be able to keep the few available surgical masks and N95 and be able to reserve them where they're really, really needed. Then if, let's say you're going home, you're in your car, at that time you can also use a cloth mask. And then I talked about the evolving case definition. Next slide, please. Team dynamics. When we first formed the COVID-19 RLT, we were all coming from different mindsets. The anxiety that came with dealing with a new disease, what we had seen in the media, what we had seen on social media as well. All of us were coming with all that, and then forming a team, the team formation dynamics. I think we dealt with that. We stormed before we normed. We did all everything you can imagine in a team. Sometimes our meetings would start at 9 and finish at 5 p.m. because we have spent the whole day trying to figure out how to agree on a particular thing that we need to decide on. But we later worked it out because we did a team building activity, which at that time was, we decided to make our own face shields. And at that time, face shields were becoming very difficult to find. We didn't know what to do. Do we buy from hawkers that we were seeing them from? And we got, we had a lecturer from JQuat who gave us the idea to do our own face shields. And we talked to people all over. We went to YouTube, we learned how to do them, and eventually we bought the material and we created our own face shields. And that's what we've been using up to now. It was a fun activity. We gelled, we became friends. I think that is how we worked out our team dynamics at that time. And then we'd do snack time laughter after that. We'd have our hospitality team do for us snacks and would eat and laugh together. I think this is what worked for us at that time. Then we had partners who join in our meetings to give us their own experiences and what they feel we can do about it. We had JQuat, like I said, and then MSF. Next slide, please. This is us after we do face shields. Amazing. Next slide. These are the face shields we made, still available in our hospital up to now. We made, I think, over 200. Next slide. I'd like to acknowledge, like I said, that we have had a lot of support from various partners, various organizations, the Ministry of Health being one of them, which has been in the lead from the beginning. then former Nairobi County, or it's still Nairobi County, and then Nairobi Metropolitan Services, the health department has been very supportive. Then the entire rapid response team, my teammates, the Mama Lucy health management team led by our medical superintendent, Dr. Musa Mohammed, MSF, JQuat and the other partners. Then we had the Ministry of Environment that donated to us some overalls for our support staff. They also donated large bins for disposal. And then we had the Global Environment Facility that also helped us to, donated a lot of IPC material. Thank you. Thank you for listening.
Thank you very much, Dr. Josephine, for your comprehensive presentation. So let us move to Dorothy to talk about public health measures. And speakers, kindly project your voices. Thank you. Welcome, Dorothy. Dorothy, are you there?
Thank you, and good morning, everyone.
Good morning.
So, just Dr. Josephine has said, mine is to talk about the other practical public health measures that we came up with, apart from the screening, the hand washing, the temperature checks. So we also wanted to protect our staff, especially our support staff, and we did a lot of trainings and reminding them how we do things. Next slide. So this is just the outline. We've kept talking a lot about safety. So use of PPEs or personal protective equipment has been something that we keep talking about on almost every day for the purposes of our safety and those of our support staff. So next slide. So we also looked into what we needed to use in various areas, that is PPEs, and our support staff would normally use heavy duty gloves, or what we call utility gloves, water resistant aprons, protective eyewear, and closed shoes or gumboots. So in the course of the training, we showed them how to take care of the gloves, which we are still doing, and how to disinfect the gloves, adhere them, and if they are pungent, to throw, so that they are assured of their protection. Next slide. That is one of the class, early days when COVID had just begun. You can see none of us is in our masks because then it was not a requirement. So we embarked on the trainings immediately the first case was announced. The next one, continuation of a training session in readiness to be sure that we remind ourselves on how to do things right. The next one. So we learned about how to mix, making of chlorine solution from powdered granules, and there is the formula. So we wanted to ensure that they know the right proportion to use when cleaning, when washing our linen, that is rinsing the linen, and also for hand wash. The formulas are two, as I'll talk about them later. You know, the formulation, chlorine comes in different percentages. We can use either the 35% or the 65%, but the formula would be the same. So what we did after working out the formula, we came up with a measure, something to measure the 14.2 grams, so that they are accurate. Next slide. Then, as I have said, protection is something that we keep emphasizing, that even before you mix the chlorine, be in the right gear. then starting the chlorine and keeping it, waiting for 30 minutes before they can use. And for cleaning and for rinsing, 0.5%. For hand washing, 0.05%. Next slide. So then, also on cleaning beds, mattresses, and pillowcases, we've kept reminding ourselves what amount of chlorine to use when carbonizing beds. Again, 0.05, and then allowing 10 minutes contact time, and then rinsing and air drying. Next slide. So the big elephant has been collection of linen and transportation from the wards to the elderly, because a lot of contamination can happen here along the way. You either hold the clothes too close to your body and contaminate yourself. So what we've been doing is to really enforce that they treat the linen, that like the linen came from a COVID patient. As Dr. Josephine has told us, we have not really had, we are not an isolation center yet, so we are not directly in our wards dealing with COVID patients, but we want to stay prepared. So we've been learning and training ourselves on how to handle linen and how to treat linen correctly, and even how to clean linen correctly. We have a designated trolley for transportation of linen from the wards to the elderly, and where the linen is cleaned. Next slide. So again, when the linen now gets to the elderly, we also remind ourselves that whoever is handling the machine must be in the right gear, in the right PPEs. Then also on how to treat soiled linen, how to switch soiled linen, then how to pre-wash the linen with detergents, disinfect the linen, and then the temperatures that must be reached by the machine, the degrees, and then about the holding for 10 minutes to kill microorganisms. Then we can hang our linen. We've been doing this, but these COVID days, we have to keep reminding ourselves to follow the guidelines to the letter. Next slide. Now on handling of COVID bodies. We have not really handled a COVID body at Mama Lucy Kibaki Hospital, but we have had a scare or so, if I can put it that way. Like patients who came and samples were taken, and they are difficult in breathing and they are in temperature. And so we were suspicious that this could be COVID patients. And before we could get the results, the patient dies. So then this body is treated like a COVID case. So what we do is that we spray the body with 2% chlorine. The recommendation is from anything from 1.5 to 2, but we decided to use 2% chlorine. So we would spray the body. After the body is sprayed, then it is packed. After which we put in the first body bag, spray, second body bag, and then we take the body to the mortuary. Now those bodies, we got a separate place for storage, a different cabinet for storage. Then they will be stored there. But fortunately, before they can go for burial, the results always came back, and both the results were negative. But these days, I know we all know that we are giving about 3 days for people to bury their bodies. So in Mama Lucy, we have not had to really bury a COVID body, but from the sub-county around us, we know what happens, that if the body was a COVID case, then after doing all these measures, then the body has to be escorted by the public health team. If it is going to another county, one team will escort to the border, the other team will take up and go and bury and supervise the burial and make sure that very little handling happens, if at all. That the only thing that the relatives are allowed to do is to identify that this is the body, and then maybe say a short prayer at the graveyard, and now the public health team will help bury the body. So thank you very much.
Thank you, Dorothy, for your presentation and for keeping time. That was very clear. So we go on to our last speaker, Dr. Emadau Karen, to tell us about COVID-19 response in pediatrics. Welcome, Karen.
Thank you, Sylvia. Good morning to all, and thank you very much for giving us this opportunity to be able to share our experiences as a public hospital, preparing ourselves for the possibility of handling a COVID patient within our premises. As had been alluded previously, Mama Lucy Hospital is a high volume hospital that experiences quite a lot of crowding. And the pediatric department is probably one of the most crowded departments you will find, second only to the maternity department. The child health and pediatrics department usually admits about 500 to 600 patients per month, and these combined neonatal and pediatric services. And our average length of stay is often quite long, especially considering that we handle neonatal cases. So with that base, you can imagine if we were unable to do anything about COVID, with all the crowding that was happening, our catchment population is basically the whole of Nairobi. And sometimes we go all the way to Kiambu counties and even Machakos counties. If we had not had some interventions done, then we felt as a hospital we will not have served Kenyans adequately. Majority of our patients are from the lower socioeconomic status, and communicable diseases are the order of the day. And as had been alluded previously by Dr. Nguri, our patients have no options. And sometimes the public hospital is the only way out. So how do we take care of this? The pediatrics department specifically, the pediatrics department specifically gets patients with a lot of respiratory illnesses. So then when COVID came in, we had specific challenges. Looking at our outpatient department, beyond the initial trial that had been done at the gate by the RRT team, we also went ahead to ensure that as these patients wait in the pediatric OPD to be seen, we took in other measures. And this included ensuring that we only have 2 patients per bench and spaced about 6 feet apart, provided tents outside with adequate ventilation if the inside waiting bay was full. And in the in-house waiting area, we had clearly marked placemats for queuing while waiting for registration. Luckily for us, we have a lot of our staff trained in the ETAT Plus guidelines. And when COVID was announced in Kenya, when we got our very first case, we had just finished our last batch of 30 trainees in the ETAT Plus. So we went ahead and used these guidelines to manage emergencies as would happen in any other setting, to ensure that we do not also lose patients with other comorbidities in the event that they did not have COVID. We also ensured that M-Pesa was the mode of payment to avoid handling cash and using that as a way of spreading the COVID infection. Regular cleaning of all surfaces, especially those with heavy traffic and frequently touched surfaces, was implemented. We ensured that everyone had masks while accessing the hospital, and the triaging of respiratory illnesses was again done a second time, because initially at the gate we did regular triaging using the case definition. Once these patients got into the PEDS OPD again, a secondary triage was done based on the condition they were presenting on and if they had respiratory illness. Next slide. So for the respiratory illnesses, we set aside a specific area for them to wait, and even review of these patients was at a specific room in the OPD. ETAT guidelines again were used for management of all other childhood conditions and also in resuscitation of patients who needed to be resuscitated. Next slide. In the pediatric ward, we have arranged it in such a way that once patients have been seen in OPD and they are ready for admission, they are pulled and taken to the ward, and then we have an admission room. So what we agreed on was that first we would not be pulling patients in the OPD. Whoever needed to be admitted went straight to the ward. Once they got to the ward, all pneumonia patients were nursed in one cubicle. In this room, we had piped oxygen and a specific resuscitation area within the room so that we avoided having to have these patients interacting with other patients who may need resuscitation. We provided necessary equipment and supplies for management of respiratory illnesses within this room. We also tried as much as possible to avoid nebulization, as this could be a way of spreading the virus. And for the children who we were following up for asthma probably got admitted with an asthmatic exacerbation, we made use of spacers that they already had and used that to help them breathe. For those who nebulization was necessary, this was done in the admission room, which oftentimes had nobody, and it's a spacious room with windows open. The caregiver was adequately counseled for this procedure, and this ensured that even if there was no other health worker with them, they were able to do this procedure perfectly. Personal protection for healthcare workers included provision of surgical masks for all health workers in the ward, in the wards. And we had thought of, as at that point in time, we did not have N95 masks, and even now we still don't have. Luckily, we haven't had to treat a patient with COVID, but we had thought of, once we have a stock, the pneumonia room may be, the health workers working in the pneumonia room may be provided with N95 masks, in addition to other personal protections. Hospital gowns were also given to these patients, as to the health workers, as much as they had the dust coats, because the dust coats we use are personal property, and usually we carry them home for cleaning. So we thought that just having a dust coat may not be sufficient, and we needed to protect our staff. So you have your dust coat, then we give you a hospital gown that you remove immediately after using for that specific shift, and these are cleaned in our CSSD. That reduces the possibility of you carrying infections to your home in your dust coats. Hand sanitizers were also provided in strategic areas. And in addition to that, we also ensure that each member of staff was given a 60 ml bottle of hand sanitizer. And whenever these was depleted, they would have it refilled, so that each and everyone at any time would have a hand sanitizer with them. We provided hand washing materials and running water, soap, and everything that was necessary to ensure that hand washing is done appropriately. We also had a plan to have all children admitted with severe pneumonia tested for COVID, because at that point in time, that was the criteria required for testing. Currently, we are able to test, although the challenges has already been alluded to. We are having a long turnaround time of the tests. Next slide, please. So we also have a neonatal service. So in the NBU, we know that deliveries are unlikely to reduce, unlike in the PIDS ward where we saw a marked reduction in the inpatient admissions. For NBU, our preterm babies are still there, and the term babies who are sick are still there. And oftentimes it's a really crowded area, so we had to think very fast and see how best to manage these patients without hurting them, and at the same time not get COVID spreading in the newborn unit. So one of the interventions we did was to ensure that the investigations were carried out at admission to aid in quick decision-making and appropriate management. And whenever we had a patient that did not require services needing inpatient care, we would discharge as fast as possible with appropriate home-based care and counsel the parents on what to do and the danger signs too. For mothers feeding their babies, we put a cutoff of 10 mothers per feeding time and did the feeding in shifts, unlike previously where we would have almost 30 or 40 mothers within one small room, plus the health workers and the patients. So this saw a marked reduction in the crowding. And we also ensure that during these feeding times, we would ensure the windows are open to ensure good circulation of air. And we also provided more heaters in the newborn unit to ensure that we maintain a thermal neutral environment. Mothers' temperatures were taken before entry into the NBU just to avoid having a sick mother coming into our newborn unit. Everybody in the room was required to have a mask. And initially we were providing 2-ply masks to our mothers while the health workers got the 3-ply surgical mask, but this was not sustainable. So we insisted that each of the mothers has to find a cloth mask to use when they come into the hospital. For the healthcare workers, again, we provided hospital gowns, and in addition to these, we also provided them with gloves as needed. We haven't so far had stockouts in any of these supplies. Hand washing procedures were emphasized, and for the new mothers in the unit, we had one-on-one supervision on how to thoroughly hand wash before they could access the room and the babies. We have a kangaroo mother care unit, and for this particular unit, we didn't do much because already we have social distancing in place and there is no sharing of beds. So all we did was encourage IPC protocols to be observed within this room, but we continued the kangaroo mother care. We also emphasized on continued breastfeeding based on the benefits of breastfeeding for those babies who could. And for those who are not able to breastfeed, we encourage the mothers to provide express breast milk. Our plan was in the event that we got a mother who had COVID-19 disease, then we would not allow the mother to come into the unit since we do not have a private isolation ward. However, we would encourage them to provide express breast milk for their baby, and we would do the feeding for them. Next slide. For the specialist clinics, there was a directive, and we all understood why the government had, whereby the government had suspended most of the chronic care clinics. And for our neonatal clinic, we suspended it for 1 week. However, we sat down as the experts in pediatrics and looked at the vulnerabilities of preterm newborns who, based on our discharge criteria, were being discharged when they were still a little bit fragile. And we had to come up with a balance between either keeping them longer in the unit until we are absolutely certain that they would definitely survive at around 2.5 kgs. This would cause a lot of crowding in the unit. So the way out was to maintain our discharge criteria, but reopen our neonatal outpatient clinic. So we were able to reopen this clinic with much fewer patients. Initially, we capped it at 15 patients per clinic, and with all the other infection prevention and control procedures that we have talked about previously in place. We also ensured that they would have social distancing, and we went out of our way to ensure that the clinic was cleared as fast as possible to avoid any crowding. Ambulatory nutrition clinics were ongoing to take care of the extremely vulnerable malnourished children who may have immunosuppression at that point in time, and we did not want to take the risk of allowing them to die while we prepare for COVID. The POPC was temporarily suspended, but we have restarted this once the government opened up these operations. And we're also considering leveraging technology in the way we do our chronic care and adapting differentiated care models into our specialized clinic services currently. The diabetic clinic was also another one that required us to give considerations, especially considering that we have a lot of newly diagnosed children with diabetes, and they may not yet be ready and are able to do everything we had taught them in the admission. So the diabetics newly diagnosed were also seen as special vulnerabilities, and we continued this clinic. We have also considered leveraging e-health in the way we do our chronic care, and we hope that with time we'll be able to present something better in terms of differentiated care for specialized clinics. Next slide. The well child clinics, we considered the possibility of what could happen if children did not get their immunizations. And we have been able to make huge strides in child health indicators improvement because of prevention of immunizable diseases. So based on this, we allowed for the well child clinics to continue as was, and we upped our game in counseling mothers and parents generally on the importance of vaccination. So we didn't see much of a dip in terms of our vaccination numbers. However, in terms of growth monitoring for children above 18 months, we saw a little bit of a dip, but that was weighed against the possibility of getting COVID infection if you are otherwise well and only coming for growth monitoring. So we also ensured that babies would get all their birth doses of immunization before leaving the hospital, and they understood that it was okay to go to your nearest public facility for other vaccinations to avoid having them take public transportation to come to Mama Lucy for vaccination. Next slide. So for CPD and departmental meetings, we've been able to leverage technology and make use of webinars, Zoom, and Google Hangouts to do our trainings and departmental meetings. We haven't seen hitches here. However, for the trainings that need skills review, we still do them, but we do one trainer per maximum of 2 trainees at any one time. And during this time, we observe all infection prevention and control measures. Thank you very much for listening.
Thank you so much, Dr. Karen, for your comprehensive presentation and also for keeping time. Since we have a little bit more of time, I would like to give 5 minutes to the 2 other panelists. If they have something to tell us, Dr. Namisi, as the infectious disease specialist, I would like to welcome you to say something, and then Fatia will say something in 5 minutes before we proceed to the Q&A.
Good afternoon, everyone.
Good afternoon.
Oh, sorry, it's still morning. Huh?
Yeah, still.
Yeah, thanks for the opportunity. I don't think I have much to say because most of what we have done have actually been presented by Dr. Josephine and Dr. Emadao, and I think their presentations have captured most of the activities that this team has been undertaking. I'm just grateful that they've given me an opportunity to chair this team, and especially for the cooperation. This has been work that has been done by almost everybody in the hospital. It's been a struggle, but there's a lot of cooperation from different departments that has enabled us to come up with the kind of presentations that you have had. So I don't think I have much to say. I'll just wait for the Q&A session so that if there are any questions, we can handle.
Thank you, Dr. Namisi. Fatia? Is Fatia on?
Yes, yes.
Please go ahead.
Morning.
Good morning.
The
department in the laboratory, we've been able to perform some of the samples. We've been collecting samples in all the departments in the hospital. Wherever the patient is, we just get them there. At the moment, we have only trained one person, so it's a challenge because at night we can't do any testing. Then we have also been able to be sending the samples, the ambulance. Immediately finish our sampling, we usually take them either to Cambridge or the NHRL series. Because of the turnaround time, we've not been able to get the results as initially with the way we had started within 24 hours. So these numbers help us a lot. We usually call them just in case we don't have results. So some of the challenges is the asthma suits. They're usually
Fatia, we seem to be losing you. Okay, so I think we'll go back to her later. So I'd like to quickly jump into the question and answer session. Our first question is directed to Dr. Fatia, we seem to be losing you.
Yes. I'm back.
Okay.
Can you hear me?
Yes, just proceed, please.
Hello?
Yes, we can hear you. Please proceed.
Okay, sorry. So I was talking of asthma suits, which are never enough. And as the media, we have been able to organize from the county, out by the sub-county lab coordinator. At the moment, we have no problem with that. Our only issue is the turnaround time of the results. It's a bit too long because results come back after a week. Like we had a case last week where the child had been discharged and then the results came back positive. It's a big issue, but at the moment we're just okay. Thank you. I think that's all.
Thank you very much, Fatia. So we move to the question and answer session. The first question is addressed to Dr. Josephine Nguri, and it comes from Dr. Simon Wangia. He says, excellent presentation by Dr. Josephine Nguri. How have you dealt with the issue of psychosocial distress and stigma among healthcare workers?
Thank you very much, Dr. Simon. Dr. Simon Wangia was my classmate when I was doing my MPharm. So thank you for that, for honoring me with the presentation. So on psychosocial distress, COVID is an issue for mental health for all of us, I included. I remember sharing with some of my teammates, even on this RRT, the initial days, how I was even having my own symptoms. I was suspecting myself. So anytime I feel like I have a bit of like some flu-like symptoms or maybe a bit of a sore throat, you're like, could it be it? It's coming, it's coming, it's coming, you know? So that happens even at work. You're suspicious of your own healthcare, your own people you work with, even at home. And a few times, maybe you have someone maybe who you know, maybe mentioned they were in a particular forum where someone was publicly announced to be maybe COVID positive. That has happened because we know we have had some public announcements here in the country, probably a leader somewhere, a church leader somewhere, a political leader somewhere, and they're like, you know, Nani was there, eh? I know they were there. So that, of course, has been an issue. I'm sure it has been an issue throughout, I think, the globe, the continent, or even globally. Currently, we have, at Mama Lucy, we have a psychologist who has been hired on locum basis, who usually takes people through sessions, whether it's COVID-19 related or any other psychosocial issue. We also have a very active social work department that also addresses such issues. In terms of health workers have their own stigma with even, let's just say, attending counseling sessions. I don't know where that comes from, yet we will advocate it to patients to go get counseling or to go see a psychologist. It's still a challenge, but I believe the Ministry of Health is also in the process of recruiting psychologists. I hope clinical psychologists as well. I hope that will actually go a longer way in addressing this issue of stigma amongst healthcare workers, as stigmatizing each other, stigmatizing patients, being afraid of interacting with someone who has had COVID before and maybe has recovered. It's still an issue, but I think we have made a few milestones here and there. Then the other thing we do as well is, I guess, talk about it if we need to talk about in our forums, various forums like WhatsApp. If we need to talk about it on WhatsApp, like, do you feel like COVID is an issue of stigma? I'm not saying we're there. We are still a bit far in terms of addressing that particular stigma issue, but I think we are doing something about it. I would ask Dr. Namisi if she has something to add. Dr. Madau as well, what's your experience from pediatrics? And the other, my fellow panelists? Dr. Namisi?
Hello. Yeah,
Yes,
thank you so
Dr.
much.
Namisi.
Yes, you get me?
Yes, please
Yes.
go ahead.
Okay. Yeah, what I would like to say about especially the issue of stigma and anxiety among staff is still a big issue. The department that is most heavily affected is the Accident and Emergency Department currently. And this is because in A&E, we receive very sick patients, and about 70% of patients who go to A&E present with respiratory symptoms. And so it's hard. COVID does not have a face. So anyone who has respiratory symptoms currently is assumed to have COVID-19. And the staff there feel the place is crowded. The staff do not feel as protected. And so they always feel vulnerable. And the issue of fear and anxiety has dominated the A&E. So we've seen that initially, in the initial times, there were even a time when staff would be very reluctant to attend to patients. But with time, one of the steps that we have taken to try and ease that anxiety is we've talked about the use of PPEs and the patient and the safety of staff if you correctly use your PPEs. So that improvement in PPEs has seen patient care improved, even of the patients who have very severe respiratory symptoms. The other thing is, as we have been conducting the trainings on COVID-19 and people are getting more information, we have seen staff take it easy, a little bit easy, not yet there, but at least we can say where we are right now is not where we began. The fear was greater initially. Yeah, but right now, when the staff are given the N95 mask, they're given the overalls, they're given the reusable gowns, and they feel well protected, then their confidence there has improved. The issue of space on how to isolate the patients who are suspected, we are working on that. And then the fact that some patients who initially presented with the respiratory symptoms were tested and actually turned negative has also boosted our staff confidence. So those are those are the steps I can say that we have taken so far. On the issue of counseling, we are still lagging behind, and this is because of lack of staff to provide psychosocial support to our staff. So we are hoping that we will make some strides. And the other issue that I have seen that staff have been agitating about is the issue of being tested. And this has been a challenge because the staff feel they are exposed, and so they feel they should be tested, and we have not been able to provide that testing. That's what I would like to say.
Thank you for that, for those responses to that question. I'd like to go to the second question. This one comes from Dr. Jayesh Pandit, and it is addressed to Dorothy. Do the public health team have any specific charges for the burial? Dorothy?
Okay, thank you very much. I would want to say that the ministry is not charging, so the services are for free. I guess if they were to be charged, we wouldn't pay for the services because the way the bodies are buried are against our cultural norms. So all of us would want to like bury our dead. So if there are any charges, I think no one would pay for them. But now that they are free service and we are not given a choice, so that is how come it is working. But I guess if there were any charges, no one would accept to have their loved ones buried by the public health officers.
Thank you, Dorothy. The next question comes from Dr. Deepak Maru, and I'd like to address this to Karen. Does coronavirus pass through mother's milk? If the mother is positive, is she allowed to breastfeed?
Thank you for that question. Now, so far, studies that have been done haven't shown transmission of COVID through breast milk. And the WHO guidelines indicate that even for mothers who are suspected to have COVID, for as long as infection prevention and control measures are done, it is possible to breastfeed. And based on this, we would not stop anybody from breastfeeding their baby if that was their choice, because the breast milk per se is not the problem. However, we would go ahead and teach them about all the infection prevention and control measures. For us at Mama Lucy Hospital, what we would do is we would not allow for breastfeeding, not because it is bad, but because we do not have the capacity to isolate this mother within our facility, to isolate her with her baby and allow for that breastfeeding. It would mean that she would still be coming into the newborn unit and exposing all other mothers to COVID. So that is the only reason we would not be doing breastfeeding. But for that specific mother, we would request, if she chooses, that she provides for us the express breast milk so that the baby does not miss out on the benefits of breast milk just because the mother has COVID disease. Thank you.
Thank you, Dr. Karen. The other issue is addressed to Josephine, and this is a question from Dr. Daniela Munene. She's curious about how you made face shields. Could you comment on that?
Thank you for that question. We have had many people ask us how we made the face shields. Interestingly, we made face shields using locally available material, stationary material, by the way. This idea came from a colleague, or we have an MOU with JQuat. We have JQuat lecturers who come in to do rotations at Mama Lucy Kibaki Hospital. And we had a particular doctor called Dr. Ashley who had come in from the US who gave us this idea, but she had made a different kind of a face shield. She came, I think, for herself. She had made for herself, but hers was a bit different. We looked at it and like our COVID team felt we can do it as a team building activity. And then we started going around. I would also like Dr. Namisi to comment on this because they're the ones who went to source on some of the materials, but most of them came from local stationery shops. The clear part of the face shield is actually that binding, whatever we bind our books with, the spiral binding we do, there's a clear part, the front cover, that's usually like a clear sheet. That's what we use as a front part. But let me just say they are locally available. And then the first time we made the face shields, we actually even did quality assurance and quality control. The first time we made the face shields, we made a few, and then we were, not even a few, we made many, because we were really excited. We probably made 100. And then we sent them out. And then when we sent them out, we thought they were going to be perfect. And all you have to do is keep doing it the way you are doing it. We got feedback that some of them, the sheet was coming out at people as people would wear. So we had to now come back again the second time and change a few parameters on how we're making the face shield so that we improve on the quality and how long, the longevity as well. So we use feedback that we receive from users on how can we do the next batch better. So the second batch, we altered a few of the procedures. And then we still said that if you still do it a third time, there's still a few things will change a bit of the, like there was a double-sided tape we were using, we might have to change it. It was not strong enough. We have a video we have made. I think we may even make it a commercial video soon because it's like we're now doing commercial manufacturing at this rate. But we have a short video we made on how we made it. If you're interested, I can send it to you. We are not charging, but I can assure you that the materials are locally available. They're not expensive. Dr. Namisi, please comment on a little bit on the source of the material.
Okay, thank you, Daniela. I just want to mention that Daniela was my schoolmate. She may not recognize my voice, but we can talk after this. So on to the face shields. The idea was given to us by Dr. Ashley, as Dr. Josephine has said. And Dr. Ashley, being a foreigner, when she showed me the materials that were required to use, I actually knew where to get those materials. They are actually sold on River Road. All you needed is some pre-cut binders that you can buy at River Road, the clear sheet, and elastic tape, which are all locally available. And you don't have to cut anything because the shops had become innovative and had actually pre-cut each and every one of those materials. So all we needed to do was to purchase them and join them using tape. A demonstration that anyone can learn within 10 minutes. So that's actually what happened. And we just teamed up and made some kind of, arranged ourselves into something like a value chain, and came up with those in a very short time. I think it was like in 2-3 hours, we had made around 125 face masks. So it's a process that it's not very difficult. We have it on video that Dr. Josephine can share.
Thank you very much. And I guess that also answers the question, a similar question from Chris Masila. The next question is addressed to Dorothy. Does Mama Lucy have any public health drives that go to communities to educate their community on corona? Since we are seeing feedback from communities saying there is no corona, how has the public health team responded to that? Dorothy?
Thank you, Dr. Elizabeth. Now, the public health team, and together with the whole sub-county, has had trainings with community health volunteers or community health workers, and has trained them on what corona is, signs, and how to protect, the protection strategies, signs and symptoms, because these are the people helping us back in the community to be able to give a signal when they see people that are presenting with symptoms that suggest that they could be sick. So this has been ongoing, and one of us attended such a training. When the early days when we began preparedness for COVID, we wanted to be able to work together with the sub-county, and so she went on a day when they were training, so we are sure that the trainings have taken place. And last week we had a training at Mama Lucy involving people from outside, and our sub-county medical officer was commending Mama Lucy for what we have been doing and saying that they are feeling our training and our measures back in the community. So as a Bakassi, I know that the trainings have taken place, and I know that a lot is happening We may not see it, but it is. And I also would want to say that when it comes to behavior change, we have issues, even amongst ourselves. Like now, I see some of the people that are supposed to be knowledgeable and good examples to others putting masks in the wrong way. Like at times, health workers outside the facility putting a mask up just to cover the mouth. And then you wonder, I thought you should know that you should cover both mouth and nose. So when it comes to issues of attitude, that is the big elephant in the house, because behavior change takes time. So I guess what we are seeing even in matatus has to do with people not wanting to adjust to the new measures, and also a bit of ignorance, and at times a bit of I don't care attitude, and those are behavioral issues. So a lot is happening even in the other sub-counties. Community strategy coordinators are PHOs who are on top of this, and the community workforce is on top of things. But there will always be those people that want to comply and others who want to believe otherwise. I know you have heard people, initially people would say that there's no COVID because they don't know of anyone that has died or they haven't seen a COVID case. But with our numbers going high, I don't think any of us can now say that there's no COVID, because we are either affected in one way or another. We know someone who is sick or someone that has died of COVID as at now. Thank you.
Thank you. The next question will be addressed to Fatia. The next two questions from Douglas Osoro, and he asks about the testing time. He's from Naivasha Hospital, and he says they have had patients stay with them up to 35 days, still testing positive on PCR. Have you had patients staying this long in your isolation? And have you had challenges with the turnaround time of the tests? Fatia?
Thank you. Actually, our facility is not an isolation area. So most of the times you realize that this is a patient who has been admitted for other reasons. Like I said, like 2 weeks ago, we had a kid who had admitted. We took the samples. By the time the results were coming back, the child had already been discharged. Those are some of the issues. And for the turnaround time, the results are 3 weeks. 1 or 2 weeks before we get our results. Hello,
Okay.
Did you hear me?
Yes, we heard you loud and clear. Thank you.
Yes.
The next question will be addressed to Karen. Comment about asthmatics and any special issues they should look out for. That's from an anonymous attendee.
So I'm not very clear on what part of asthma he would want to get. So I'll assume that you're asking about whether we should worry about COVID in asthma. Yes, it's one of the immunological diseases. So we will need to give more care. Among the people at risk, we list asthma as a respiratory disease that affects lung function. Therefore, those children will give a little more attention whenever they're admitted with an asthmatic attack. And then during this particular time, we are taking precautions to ensure that they don't end up with asthmatic exacerbations. One of the things we've done as Mama Lucy Hospital is probably something we didn't mention, is to start up a respiratory service that also takes care of chronic care. And we are specifically targeting the asthmatics so that we don't have them crowding in the other areas. So we are giving specific care, specific education to ensure that they don't have to keep coming to the hospital and exposing themselves. That is my understanding of that question.
Thank you very much. So the next two questions are from Dr. Deepak Maru and Dr. Esther Maina. I'd like to address them to Dr. Namisi. The first question is, are there charges for COVID testing in government facilities? And the other question is, have you had challenges referring COVID-19 patients now that there are claims that most hospitals with isolation are full?
Thank you, Doctor. Thank you, Daniela. On the first question as to whether there are charges or not, I'll specifically speak for Mama Lucy Hospital. Currently, we are not testing for COVID at Mama Lucy Hospital. So what we do is whenever there are suspect cases, our laboratory staff take samples and they take them to the National Health Referral Laboratory or KEMRI, and they are tested and we get back the results. And this is done for free. There are no charges to that effect. Our lab staff have also encountered some patients, or rather not patients, but when it was announced that for cafeterias and restaurants to open, the workers needed to be tested. Some of them started coming to the hospital and requesting for testing. So such individuals were then referred to some specific area. Here in Nairobi, there's a place at Lady Northi that the county has organized to handle, and there they pay. I'm not so sure how much they pay, but they're supposed to pay for that test. For those who go to private hospitals, because of the delays in receiving results, some patients would opt to go to private hospitals or even to Lancet, and in those facilities, they pay for that test. To the second question, as to the challenges with referral, I think Dr. Emadao can attest to this. Right now, no facility is accepting a patient with respiratory symptoms who has not been tested for COVID. In fact, they're not accepting any patient who has no COVID results. So that's a big challenge because COVID results are taking so long to come back. The turnaround time is as long as 1 week sometimes, and you have a critically ill patient who is desaturating, who needs ICU care. So we have a very big challenge when it comes to referral, especially now that we ourselves, we are not a COVID treatment center. The second thing is right now, the facilities that have been registered to treat COVID in Nairobi are getting full. This is KU, Kenyatta Hospital, Mbagathi, and Mbagathi. Those are the areas that we know in Nairobi. So these places are now full. And sometimes when you have a patient that you suspect, about a week ago, we had a patient who we suspected to have COVID and needed ICU care and extra care. And this patient had to go to St. Francis Hospital. And the results came back after 2 days and they were positive for COVID. So as you can see, that is a very big challenge. Nairobi, right now called the NMS services, needs to expand the capacity to take care of COVID positive patients.
Thank you very much. I'd like to field the last question. There are so many questions, we are not able to answer all of them. So please bear with us because of time. I'd like to ask the last question, and then I will hand over to Dr. Daniela, who has an announcement to make. So the last question comes from Dr. Elizabeth, and she asks, there has been request of patients to get BCG vaccine to protect against corona. Have you experienced this, and what is your advice? I'd like to field the question to Dr. Karen.
Thank you, Sylvia. So BCG has been a buzz in the whole world, but for our population, BCG has always been given because we are a TB endemic zone. It has been so for the longest time possible. We've never stopped giving BCG. However, in the first world, they do not give all their children BCG. So knowing that BCG in itself gives non-specific immune responses, there have been some studies that suggest that maybe it may have an effect on COVID. Clinical trials are still ongoing, and as of now, its effect on COVID is not known. Until those clinical trials are concluded, we cannot use it as a way of saying we are going to use this in the adult population or in those who did not get it as a preventive measure. As at the last I read, the WHO still does not recommend the use of BCG as a preventive measure. But even if it did, I think for our population, we are already covered. Thank you.
Thank you very much, Dr. Karen. Please allow me to hand over to Dr. Daniela. Daniela, please.
Thank you, Sylvia. And thank you very much to our distinguished panelists. Dr. Namisi, it's good to reconnect after a long time. Now, we just got news that one of our prominent members passed away yesterday with a sudden stroke. So I would like us to hold a moment of silence for our late brother, Dr. Njoroge Keige, who was a pioneer African pharmacist who broke the ceiling into new frontiers in the pharmaceutical business. He founded Omaera Pharmaceuticals that we are all aware of and have interacted with in the health sector. Omaera was a big inspiration to all pharmacy professionals and other colleagues in the health sector. This untimely and tragic loss is monumental, and may the Lord Almighty comfort his wife, Dorcas Njoroge, and the entire Keige family, and the entire PSK fraternity. Let us take a moment of silence for Dr. Njoroge. Okay, thank you very much for that respect. And so I'd just like to give a vote of thanks to our speakers today, Dr. Josephine Guri, Dr. Florence Namisi, Dorothy Wawero, Dr. Karen Emadao, and Fatia Swale. We appreciate the time you took to come up with the slides and the very rich information you shared with us today, and for availing your time this morning to interact with our members and other healthcare professionals on this webinar. We wish you all the best as you run the rapid response team at Mama Lucy, and our thoughts are with all healthcare workers in the front lines combating this pandemic. Thank you, Dr. Opanga, for moderating this session very well. Thank you, Dr. Peter Odhiambo, for sharing the slides with us. And thank you to all participants for hanging on until the end of this webinar. We welcome you back next Wednesday at 11. Next week, we are going to be talking about field epidemiology. So please tune in again at the same time. For now, it's goodbye. Thank you.
Bye.
Bye-bye.
Bye. Bye-bye.
Bye. Bye. Thank you.